right, thanks everybody. So we're gathering together here again just to follow up on recent announcements. And you are some of our signatories to the call to action for better planning, better care, and better work through better data. And since April 2021, so it's been almost 2 years, we have over 70 organizations that have signed on and over 300 individuals. So we're well over 400. All names are posted on the website for the Canadian Health Workforce Network, and also like the Google Forms that we have. So at that time, we called on the Government of Canada to support health workers by making significant and immediate investments to enhance the data infrastructure that provinces, territories, regions, and training programs need to plan for and support the health workforce. So again, the really important point is that better data was a means by which we could get these other things. So it was not going to be an end in and of itself. So that's what we asked for in the call to action. Could the Centre for Excellence for Health Workforce Data get us there? And what seems to be missing? So just to remind everybody, this is what was announced February 7th, 2023 in the Working Together to Improve the Health for Canadians. The Government of Canada will provide $505 million over 5 years to the Canadian Institute for Health Information and Canada Health Infoway, and federal data partners to work with provinces and territories on developing new health data indicators and to support the creation of a Centre of Excellence on Health Workforce Data and underpin efforts to use data to improve healthcare. So that's the text of the announcement. That's pretty much all we have to go on. So at around the time that we were developing the call for action in 2021, I was invited as part of a group that was organized by PG Force to prepare a series of policy briefs for the Deputy Minister at Health Canada. And long story short, this is the visual that represents what was being promoted in that particular brief, which is hyperlinked at the bottom. We were basically saying that federal government could provide strategic investments in 3 key elements that will improve data infrastructures, develop early warning systems, of which we have none, and inform decision-making. So it's really about having a stronger data foundation through standardized health workforce data and building and embedding capacity in health workforce data analytics in order to have timely, accessible, and interactive decision support tools, with the ultimate goal of having better decision-making. So really, to emphasize the point that health workforce data are a means to an end, that you have data ideally standardized on the population and the health workforce side, that goes into modeling. And then out of that modeling will be a set of interactive decision support tools. That is quite distinct from planning. So really to emphasize, planning is more than modeling. And in fact, some of the data informs planning that is more what we call health workforce intelligence. It's more qualitative data, what's happening on the ground, that doesn't necessarily mathematically go into a model, but it informs that process. So health workforce data are much broader than quantitative data. And really importantly, at the bottom, what we miss here and often in other countries is implementation, actually making decisions based on what the data modeling and planning exercise suggest. So that requires capacity to implement the changes based on the modeling and planning exercises. So that's what that process is. So these are the typical integrated functions of a health workforce collaborative or agency or observatory, whatever you would like to call it. These are the core functions. And that is based on sort of inspiration from a review of different international observatories. So first, collecting, synthesizing, and sharing standardized data, developing early warning systems based on those data, curating evidence and sharing strategies, conducting applied research and policy evaluation and analysis, developing partnerships to mobilize stakeholders around policy coordination, and building capacity and facilitating networking. So let's start with the health workforce data function. And we have here CHWN, but other federal agencies that were noted in the announcement, Statistics Canada and ESDC, Employment and Social Development Canada. So here's one of the Canadian health workforce data pathways that is most salient to most decision makers. And here's the pathway. Provinces and territories require provincial regulatory authorities to collect data for a registry. That is what they are required by statutes to do. Professional regulatory authorities collect registry data from registrants on a yearly basis. And that is a requirement. Voluntarily, professional regulatory authorities share data with CHWN through a series of data sharing agreements. Part of the problem here is that once the data get to CHWN, it takes a long time to get there, and it's often there in a very non-standardized way. So there's a lot of work that CHWN has to do to tidy those data to be released publicly. So that's a lot of energy and resources. So some of the key challenges here with the data coming from provincial regulatory authorities or colleges is that the data pathway is time and resource intensive due to a lack of data standardization. The data are siloed by occupation and province with limited common data elements. There's aggregate level data only for most others. And by that, we mean age, gender as a binary, male, female, and province. That's it, 3 data points. It also excludes certain health workforces, and that would include unregulated workers like personal support workers and the 20 other different names that we call them across Canada. Mental health and substance use providers beyond psychologists and social workers, also very little data in that regard. And it also doesn't include any data on internationally educated health practitioners who are here in Canada. So there are some really important blind spots in the data. In addition to that, there's little, if any, equity data elements on racialized or Indigenous identity or language ability. And these are things required by federal legislation in terms of Official Languages Act, in terms of the calls to action for truth and reconciliation, which is not so much a requirement under legislation, but has been a call, and also employment equity legislation. So much of these data are not designed for health workforce planning, and there are restrictions in the data that we have in terms of legal data sharing agreements, public accessibility in terms of being able to utilize those data for decision-making purposes, and usability. So these are some important challenges that could be addressed. Now, there are some promising activities undergoing. So CHWN is updating its cyclical review of the minimum data standard, and they released that in September 2022. That applies to the professions that they gather much more granular data on. So it doesn't apply to medicine, and it doesn't apply to many other practitioners. CHWN has partnered with us at the Canadian Health Workforce Network with a CIHR-funded project to look at an enhanced inclusive health workforce minimum data standard purpose-built for planning. That work is in progress, but it's really important to note that whatever we produce out of the CIHR-funded project would need to be adopted by CHWN and would still be a voluntary standard to apply to the different regulatory authorities. So requiring different layers of adoption is very, very important to note. So it's promising though. What about Canada Health Infoway? Because they were noted in the call. And I personally found that quite interesting because Canada Health Infoway is often not sort of considered part of the different stakeholders in the health workforce arena. So given that the data pathway to CHWN is time and resources intensive due to a lack of standardization, there are 2 particularly promising activities that Infoway could support. So for example, creating a platform for aligned data collection and reporting across the different regulatory authorities, collecting that data and sharing it with CHWN in a much more timely way, safe and secure. InfoWay could also enable the collection and transfer of detailed service data from hospitals and EHRs for even more enhanced health workforce planning. And indeed, the minimum data standard that we're developing with our CHR funded project has an added component of a service module, which will really catapult us ahead of many other countries in terms of the types of minimum data standards that they have. So it's really exciting, and it would be amazing if InfoWay could support it in this way. But these are just proposals. I don't know exactly what is being envisioned for Canada Health InfoWay. In terms of other pan-Canadian or federal health workforce data pathways, it's important to note that there are others, and I just want to talk a little bit about the one in yellow here. So Economic and Social Development Canada, or sorry, Employment and Social Development Canada creates national occupational classification codes, and those were just renewed in 2021. They do a renewal of these every 10 years. StatsCan collects data against or utilizing the National Occupational Code, depending on the sample size they'll collect it at the 4 or 5 digits. And then some of the projection models that they have, again, within ESDC, an example here, the Canadian Occupational Projection System utilizes StatsCan data for workforce projections. There are two challenges with these data. The regulated titles of different health workers doesn't match very well with the national occupational codes, and that's particularly problematic. And it's important to note that the survey data that we're getting from ESDC and StatsCan are as important as registry data or admin data, but they need to be aligned. So because of some of this difficulty in the alignment, some of the projections for the Canadian Occupational Projection System are wildly inaccurate. And so there's money and resources going into this. If we could align this better, that would be a much better use of the funds that are developed there. So it's important to note that there are different types and sources of data that are needed to inform modeling and planning. First, you have registry or administrative data. That goes actually into the models. So you have a census of health workers, and you want to leverage that data from regulatory authorities in the form of registries. And that is an annual self-reported data. But you can augment that with admin data from employers or insurers that you can gather that on a more daily, weekly, or monthly basis. And that doesn't require a high data burden. You know, it doesn't need to be self-reported. But that can also be augmented by survey data that would go into those scenarios, go into that, orange bar of that map of data modeling planning. So this is a sample of health workers, where we could leverage data from pan-Canadian agencies such as StatsCan through their labor force survey, through their vacancy surveys, and also from practitioner organizations that are collected on various time periods. And those can either be through membership data, that's administrative, or self-report data. The principle here is to collect data once and use many times. And in fact, guidance that will be coming out from the WHO around health practitioner regulation is really to leverage registry data for health workforce planning. That should be coming out shortly. But there are other health workforce data pathways and a broader range of data providers that could be aligned, that could adopt a minimum data standard, that we could pool those data together. And so we talked about that first red bar already. But what about education and certification organizations at the provincial territorial level in terms of training programs, and then the national associations? Like, where do those data go? How about funding and remunerative stakeholders such as employers and insurers? Do those data go into national associations of employers and insurers? And then where does that go? How could that be aligned? And the same thing in terms of the data that are held by unions and professional associations. How does that get gathered up and traveled? So these are other data pathways that really could be leveraged to have much better workforce data. Because it's important to note that planning is an exercise that requires a broad range of governmental and non-governmental stakeholders, and they need to be engaged in an open and collaborative way because it's not an exact science. Planning is different than just modeling. And so I'm not going to go through all of the different providers here, but this is our our complex adaptive system of health workforce stakeholders that look at issues around governance and funding and education and research and knowledge exchange. If you can see the complexity in this diagram, you would say this needs to be coordinated. And that is exactly what Mark Britnell said in his book, Human, published in 2019, where they were talking about the global health workforce crisis in 2019, which has only exacerbated because of the pandemic. And so he makes the argument, it is possible to make good this gap in the health workforce crisis by orchestrating our policies and practices in a more innovative, concerted, and collaborative way. It will involve the determined and careful coordination of many different agencies, institutions, and organizations, which left to their own uncoordinated and fragmented efforts, by design, they are by design to do different things. And because of that, they will fail if we do not coordinate them. So is a center of excellence for health workforce data enough? What would be missing? And I chose this visual quite specifically because, when you look at your cell phone and your battery's at this level, is that enough for you? Is that enough for something that is 10% of the working population in Canada and 8% of Canada's GDP? So what about all of the other functions of a health workforce collaborative? Well, quite clearly, we do not have an early warning system. So that's a complete red. Everything else is kind of amber. We're kind of doing some of it, but in a very uncoordinated and not entirely dedicated way. So Healthcare Excellence Canada, the Mental Health Commission of Canada, other organizations, our tiny little Canadian Health Workforce Network, which has 0 funds. We are a volunteer organization. We aid in some health workforce strategy sharing and capacity building, but again, a lot of that is not fully dedicated. This could be enhanced through targeted investment to collaboratively build capacity to spread and scale integrated, evidence-informed retention, return, and recruitment initiatives, what we call the RRR. CHR is also an organization that we should mention, and it was not mentioned in the announcement. It funds health workforce research, but very little, and it is very small in terms of capacity building. How small? Well, this is the visual that they're using. Less than 3% of health services and policy research addresses health workforce issues. And then when you know that less than 7% of CIHR funds goes to health services and policy research, 3% of 7% is a minuscule contribution. So if we talked about strategic investments through CIHR, which is fully within the domain of Health Canada, to embed scientists to enhance capacity in each province and territory in support of health workforce modeling and planning, that would be a huge step forward. So what's missing from a Center for Excellence on Health Workforce Data, and these are the 4 things that I've kind of summarized, but I really want to hear from you. We're thinking that its investment in health workforce data still requires accessible decision support tools. And secondly, if health workforce data includes evidence-informed retention, return, and recruitment initiatives, support for spread and scale is still required. So it depends on how broad you are thinking health workforce data are. We also require investments in building analytic capacity and research capacity. And the details regarding leadership and governance are still required. So I'll just stop here with some of the potential action items that came from our conversation that we had earlier today between 12 and 1. Some discussion was around revising the call to action, developing a white paper, creating a bit of a big huddle, developing a shorter, pithier 5 key item bulleted list that would then be integrated into a letter to the minister and or others. Also requesting an audience with the Committee on Health Workforce, the Federal, Provincial, Territorial Committee. And then following up with an op-ed or a series of op-eds, perhaps one around each bulleted list that all of us could participate in. So I'm just going to stop there, and I'm really looking forward to your feedback and really want to encourage us to move forward with that conversation. So thanks.